Good evening, everyone. Today is Sunday, July 26th, and it's a pleasure to be back with you again for the Lupus Virtual Town Hall. We want to thank the sponsors of this weekly event, and that first and foremost, the Lupus Foundation of America, Georgia chapter. With Terry Iman and the rest of the crew. They've been with us before, during, and after this pandemic, or will be after this pandemic. They've always been providing the utmost critical updates and information each and every day, not the least of which is the COVID resources that they have on their website. So please go check them out and support the chapter. The Georgia Council on Lupus Education and Awareness is one of the very, very few state-supported councils on lupus anywhere. And we're lucky enough to have one headed by Chris Reed and Kim Schofield, Representative Kim Schofield. And Georgia is also the home of one of the very first and few CDC-supported lupus registries that have gone on to become what we call a prospective cohort, a research cohort called GOAL, Georgians Organized Against Lupus. It's housed within the Division of Rheumatology at Emory, and Grady, and myself, and Christina Drenkard, and Charmaine Dunlop-Thomas, and the rest of our staff have been working with many of you in terms of learning more about how lupus impacts those in our community and spreading it to the other scientists and people throughout the country. So thank you. So we'll get into it. New since last Friday, we have over 15 million confirmed cases worldwide, along with over 636,000 deaths. And the US has reached the 4 million confirmed cases mark. And as you see, we're over 147,000 deaths. We have Brazil, India, Russia, South Africa among those with the highest numbers of total infections. And this week, it really hasn't changed much from last week in terms of global hotspots. You continue to see the US is still blazing hot in terms of not only the weather, but also new infections. Most of South America, South Africa, and parts of Asia, including Russia and Kazakhstan. In the United States, this is last week in terms of hotspots. You can see various parts of the West, particularly California and Arizona, but definitely all throughout the Southeast. And this week, it's pretty much the same. Some of the areas that you see from last week to this week that have become sort of white, I think it's more for reporting delays than anything else, but it's essentially the same. California passed New York as the state with the most COVID cases, and Florida and Texas are on track to pass New York as well this coming week. And so cases continue to surge throughout many states, particularly in states who are among the first to reopen. And cases have increased in 40 states in the last 2 weeks. The only 2 states that report declining cases this past week were Maine and Arizona. You know, keep in mind, Arizona had a ton to begin with, so it's good news that they're coming down, but it doesn't mean they're out of the woods. Before I go to some of the data, more granular data, one of the questions that came this week was, can you comment on the availability of real-time data? Are deaths recorded on the day they happen, or is there a lag time? There inevitably will be a lag, and it depends on the different states. And, it takes time for these things to be entered into, extracted from the databases locally and then transferred into more of a central database. And then from there to be analyzed by the public and distributed. So there certainly is a lag, but it's not a dramatic lag. I mean, this is on the forefront of all the public health efforts. So the data that's coming from hospitals, morgues, unfortunately, the testing facilities, they're probably on the par of a few days or several days. And so looking at things trending from week to week is probably fairly accurate and relatively up to date. So these are from last week in terms of new reported cases over time and up at the top, and new reported deaths across the US at the bottom. And that's last week, and you can see this week. So last week, if you look up at the top in terms of new reported cases, and then this week you see basically the rates of new cases have flattened a bit, but look at how high we are in the overall curve. The US now is averaging about 70,000 cases, and if you look at the bottom here, the deaths have definitely started to come up and continue to come up. And the deaths are about 800 deaths per day, which is, if you combine the two, 70,000 cases and 800 deaths per day, which is at the rate of one Wuhan each and every day. I mean, if you think about that, where the virus came out and was devastating in terms of a large city in China, we're basically pacing at that rate of one Wuhan city in terms of cases and deaths per day in the US. And you can see here that there are certain parts of the country that are doing better than others. And it can change on a dime almost. And you can see how poorly New York, New Jersey, and Connecticut were doing, and it wasn't that long ago. And now they're dramatically down in terms of the number of deaths. And here if you take about the overall average, 7-day average of the US, it's gone up, it went down, and then it's starting to go up and continues to go up. Here in Georgia, we know about the legal tussle, philosophical, political tussle between Governor Kemp and Atlanta's Mayor Keisha Lance Bottoms, along with other jurisdictions and cities in the state. As that's trying to go through mediation, but it's hitting a lot of snags. We're just gonna have to wait. But we've talked about it many times over the past few weeks. We know the data behind the masks, and we hope that regardless of what happens legally and politically, you all will continue to do what's good to protect you and your family and your friends. This is last week in Georgia in terms of the hotspots, the list of Georgia counties in terms of total number of cases. And this is this week. Again, I think the white spots are really more of reporting delays, but it's essentially the same last week, this week. It's still pretty hot throughout the state. And again, ranking of the counties in terms of the number of cases. I put in this slide here, I changed it so that it ranked the counties not in terms of pure number of cases, because that is also a measure of the population. So the one slide before, I mean, it makes sense that you're going to have most of Atlanta's counties just by the size of them, that they're going to rank amongst the top. But if you look at per 100,000 cases, 100,000 population, the number of cases of positive COVID, you can see that there are some counties here that are more in the rural areas. So this is where you really hit hard in terms of pure frequency, total number of cases over the population denominator. So in Georgia, this is up here, kind of putting together the similar figures that I showed earlier for the entire United States, but specifically for Georgia. You see Georgia went up, and in terms of new cases, and this is at the early part of the pandemic when things were locked down. We didn't know much about the virus, but we locked down, and we locked down hard. And you can see that even though it went up dramatically, the effect that it had, it never really resolved in terms of the first peak, but it certainly flattened the curve. And you can see that it overall trended downward, but we made, many people would argue, including myself, that we reopened too quickly. And so therefore now we're seeing, look how dramatically high the number of cases are compared to how dire things looked in the very beginning. We're several fold higher in terms of the number of cases. And in terms of number of deaths, we certainly had a lot more deaths early on, and that's in large part that I'll touch on in a minute. The age difference, we had many people, especially in the senior centers, older people in general, those that had a lot of comorbid conditions that had what we now know are the highest risk in terms of some of the poor outcomes. And now we have the pure volume of mostly younger people, but even then it's going to catch up to some of them. And then through the younger people, there's transmission to the rest of us that are older and have other issues. And so now we're starting to see that effect in terms of deaths too. So it's getting to the point where it's almost matching the high rate of death before. This is what I showed last week. This is out of the COVID Act Now website. It looks at Georgia with regards to multiple parameters, if you will. And this is in terms of available ICU beds. ICU beds are being used, actually. So last week, in terms of throughout Georgia, it has 2,833 ICU beds. And it was occupying a high proportion of those beds to the point that it was in a critical range. About 88% of available ICU beds are taken. So it doesn't leave much room for a large number of new cases, especially from COVID, to come and crowd the ICU. Here, this week, we've passed 88%, and we're basically at 98%. So we're just touching full capacity throughout the state in terms of ICUs. So there are plans already underway in terms, and you might have heard about them, expanding hospital beds, ICU beds, portable units, going into convention centers. It's just like Groundhog Day. It's what we were trying to avoid, we've come back full circle. And for those of you who want more detailed data in your particular county, this COVID Act Now website, you could really drill down to every single county throughout the country, but especially in Georgia, you can go to your own county and you can see in your neighborhood or in your surrounding area the number of new cases, the infection rate, the positive test rate, the ICU beds available, and how effective the contact tracing has been. Statewide and regional hospitals, throughout the state, we have over 3,000 COVID positive patients in the hospital, and we hit the low on June 7th with 743 throughout the state. And so here we are at 3,000 plus. So again, just reiterating how we really bounced back, unfortunately, to the bad end of much, much higher numbers than we had before. And then you can see the statewide and Atlanta regional hospital capacity in terms of ICU and general inpatient beds. And this is inpatients in the metro Atlanta area. The top is total COVID positive patients in the hospital. So it went up, went down. Now we're going really, really high, higher than we've ever been before. And as I mentioned, the ICU, COVID positive patients up, down, and now it's going really high and straining available ICU capacity. As many of you know, I practice mostly at Grady, and this is very similar to what's happening throughout the rest of the state. You can see here March, April, May, June going down, and you can see the average age. Basically, early in the pandemic, the average age was in the 60s, and now it's in the upper 40s and low to mid 50s. Significantly younger, but still, this is average. So you still have a lot of people across all the age spectrum, as you would expect in the pandemic, but certainly we have our fair share of younger people. Here's one question. Also, I'm sorry, with testing, how are we to get a realistic number of who's positive when results are taking 5 to 10 days? Can there be effective contact tracing with a long delay to get these results? I think you pretty much know the answer to your question, but to be clear, we'll get, if the reporting and the testing is accurate, we get realistic or accurate numbers. But I think the point is, if you have it 5 to 10 days later, it's really of no use for the individual, because by 10 days, you're pretty much hopefully have been quarantining and probably less and less infectious and having less symptoms. And so the whole point of getting testing and identifying really early, and especially for the asymptomatic people, the key is to have it much earlier. And in terms of contact tracing, you're absolutely right. If you don't know who's positive as soon as possible, then again, you don't utilize that information not only to isolate individuals, but to try to find others who have been in contact with that individual as early as possible, in case some of them are positive and infecting others. So the more time goes by, the less effective all of this is. So we really need testing and tracing if at all possible, but it all starts with testing, and that informs other measures like tracing. And this is a nice update or report produced by the Rockefeller Foundation, and you can go to this website to see a summary and also download the full report. But here, it talks about basically these principles that we need to massively scale up fast, cheap screening tests to identify, especially those who are not yet symptomatic, who are currently infected. And this could be people who just routinely test themselves. If you're in a high-risk environment, if you're working in schools, you're in a high-service type of occupation, if you're in healthcare, if you're immunosuppressed, wouldn't it be great if we had fast, cheap screening tests that are readily available that gave us results quickly? And we need, based on the numbers and the populations that we have, we need 30 million tests per week. So remember that number, 30 million tests per week throughout the US at a minimum. And then we need to reduce the time that it takes for the results to come back from the current 5 to 14 days to a 48-hour maximum turnaround time. So we need readily available tests, and we need a lot of them, and we need these results to be accurate and cheap and in our hands, and to those who need it within a couple of days. So it's one thing to reopen, it's quite another thing to remain open, and that's what we're unfortunately finding out now. In terms of Georgia, if we're doing enough tests, and we're getting things under control, the positive rate should be about 5 to 10% at the most. But you can see here, this is a reflection of the number of community positive patients that we have, along with the poor amount of testing that we have. And then you can see here that the contact tracing is very few. I mean, it's basically ineffective. Only 7% of the cases are being tracked, meaning we have a way to get people who have been positive, we get their test results relatively early, and we have a method in which to interview them, find out who they might have been in contact with, and then to reach out to those people. And I had a slide that I didn't have time to pull up, but I showed it a few weeks ago. But the experience from New York and New Jersey shows us that it's going to be tough. I mean, contact tracing works well in a country like South Korea, where it's relatively homogenous and people buy into one system, and they have a pretty quick and effective way to identify individuals. And there's not really much of a concern, as much of a concern in the individuals as to what their government is doing. The US, we just don't have that. We have a very heterogeneous society. We have groups of individuals, especially minorities, that are being really hard hit, especially Hispanics and African Americans. And you have the government sort of prying and asking them, well, where have you been? And who have you been with? And you're not going to get very quick answers. So contact tracing, I think, is certainly something that we should continue to try. But I think, I'm sensitive to the fact that it's just not going to be as effective, and this percentage isn't going to be as high as we want it to be. But we should keep trying. Where we don't have an excuse is in terms of the testing that should be available and the results that we should have very quickly. So based on at least 30 million tests per week that the nation requires to get to the point where we should be able to have knowledge and as many people as possible to really kickstart safely opening up and keeping open our workplaces and our communities. Here, Georgia ranks really poorly. Georgia's right here in terms of the amount of testing that we're doing. We're just having way too many positive tests, as I've sort of mentioned in an earlier slide. So here is a question. My brother keeps saying that 99.8% of people who get the coronavirus will be fine. Are there any studies showing the duration and severity of the virus? Are there any long-term effects? And yeah, this has been, this has some truth, but it's really twisted in terms of the overall truth. And it's been an issue that's been around from the very beginning. How some people have sort of spun this as maybe a variation of the common flu. And, to some degree, I think if you compare it to measles, which is extremely infectious, thank goodness that COVID-19 is nowhere near measles. And that's why it's crazy that measles has actually started to come back before COVID. And because of this whole push for people to be really insecure and wary about immunizations in general. But as a country, we basically knocked out measles up until recently, and for good reason. When it was around, people knew how really bad things could be. Measles stays in the air for hours. It's that fine of a particle. It's so infectious that you have one individual that's infected with measles that's been in a room and leaves, and you're talking the next 18 people that get exposed to that, for that each individual can get infected, and then they're going to infect other people. And so you can see how tremendously infectious it is. Now, compared to the quote unquote common flu, COVID is about twice as infectious. And so you can look at it compared to measles, and it looks like common flu and COVID are pretty much the same. But nonetheless, it's still very infectious. About 2.5 to 3 people per every individual with COVID gets infected, if there are no measures to limit exposure like distancing and masking. And I've showed this slide before. What's so devious about COVID is its long asymptomatic period. So you have 14 days where people just don't even feel that they're infected most of the time. but they are actively infectious. And so these 2.5 people quickly become 406 people infected in 30 days. And those 406 go and each one of them become one of these people. And so the power of spread of COVID, regardless of what you think of flu is extremely high. And it's quite infectious, even more so than the common flu. Now, if you look at it compared to some of the other flu viruses that have been around before, and compared to the H5N1 bird flu in 1997, some of you may remember, or MERS or SARS, this is the fatality rate for how many of people infected, what's the percentage of people who die. So you're talking rates about 50 to 40 to 30% of these previous viruses, Ebola and so forth, died. And so that's extremely scary. And if you look in that context of that, the COVID virus is 2.2, but it's much higher than what we're seeing with the quote unquote common flu. And I showed this slide in some form, I think a few weeks ago too, but this gives you just a flavor of the difference between the common flu and COVID. So you're talking annual death rates from 2015 to 2019, and you can just apply that over in the background here. And this is all deaths. We're talking motor vehicle accidents, poisonings, and the flu itself. And so I'm not saying this is all flu, but flu is in there, obviously. And you can see overall that the death rates tend to remain fairly constant. I mean, there's some little ups and downs, but certainly within a range. And, but if you look at when COVID has started, you can see this huge increase in death rates. And this is in Massachusetts, but it's reflected in all other states. This cannot be explained by anything other than COVID. And to have a virus have this kind of signal in the death rate, just should tell you that it's not the common flu. Yes, I mean, what's twisted is you can look at one angle and say, yes, a lot of people remain asymptomatic or have mild symptoms, especially now because there are a lot more younger people getting it. But that doesn't take away from the fact that because it's so infectious, the total numbers are so great, and it eventually gets into the younger and the older, especially the older, and those that have comorbid conditions, including immunosuppression. This the death is we've already seen the big peak due to COVID. And if that wasn't enough, what's come out recently this past week in the CDC journal, the MMWR, is this story. And this report indicates that even among symptomatic adults tested in outpatient settings, not in the hospital, it might take weeks for the resolution of symptoms and return to usual health. So these aren't people, quote unquote, sick enough to be hospitalized for COVID, but it's taken them weeks to really go back to how they felt before. So not returning to usual health within 2 to 3 weeks of testing was reported by about 1/3 of people. And even among the young people, so if you're relatively young, you've escaped all of this stuff, even amongst adults aged 18 to 34 with no chronic medical conditions, nearly 1 in 5 reported that they had not returned to their usual state of health 14 to 21 days after testing. So this is in contrast to the common flu, as we just talked about. Over 90% of people in the outpatient arena with influenza recover within approximately 2 weeks of having a positive test. So 90% get better with the flu within 2 weeks. And just in the very young with no medical conditions, 20% have symptoms at 3 weeks and even longer. So these findings have important implications for our understanding of the full effects of COVID, that even in persons with milder outpatient illness, there can be sort of a prolonged recovery phase, even in those without chronic medical conditions that are potentially leading to prolonged absence from work, studies, and other activities. So this isn't just something that you stay home, drink some soup, and then you go back to work the next day. This could be a little complicating for things down the road. The American College of Rheumatology has a clinical guidance for adult patients for rheumatic diseases, and they just added a couple of things to it this past week. And for those that, along with their doctor, stopped some of their treatments, and I emphasize that because even though some of you, and I'm hearing many more each and every week, are getting positive with COVID, and that's to be expected actually, given how much there is out there, don't stop any of your medications. In fact, there's no reason to do in some cases. In fact, I mentioned in the last week or two, there are some medications that are associated with even better outcomes. So don't play around with your medications, talk it over with your doctor. But there are times when, with your doctor, you might decide to come off of a medication because of COVID symptoms and infections. And here they're talking about restarting them safely in 17 to 14 days after symptoms resolve. But I don't think this is really taking into account some of this new information from CDC that symptoms can stick around for a longer period of time. And it doesn't mean that you're infectious. So again, I mean, this is all part of what we're learning each and every week, and more reason to continue to discuss this with your healthcare professional. What do you recommend for parents with lupus on Benlysta, with kids in middle school, in high school, virtual learning or in-person learning in school? Is there a way, if there's no way to avoid in-person school learning, what recommendations do I have? Well, I will say that we just don't know about these medication effects on people with lupus just yet. We're learning more and more. The good news is that there doesn't seem to be any medication in particular, Benlysta or otherwise, that is just automatically a no-brainer that you must stop around somebody with COVID because you have a high chance of dying or severe complications. We have not seen that yet. We have seen something like high doses of prednisone that are associated with more complications. But keep in mind, high doses of prednisone is a marker of severe disease, so it could be more severe disease that's affecting it. There are other biologic medications like anti-TNF medicines like Enbrel and Humira that are associated with better outcomes. People don't stay in the ICU as long on those medications, it seems. And these are just not just lupus patients, but mixed in with other rheumatic diseases. So my point is, I don't have good guidance with any particular person about lupus in general and their medications, other than to cite what I've just told you. All of that is really to say and underscore that you shouldn't be changing your medications based on any particular fear. Again, talk it over with your doctor. You shouldn't be on anything that you really don't need anyway, especially during COVID. But if you need Benlysta or any other medication for that matter, for severe issues that were not under control before, I mean, chances are it's probably worth staying on. But again, it's an issue that you need to discuss with your doc. And then with regards to some of this other aspect about returning to school and not returning to school, we talked about some of this last week. You can go back and view that video. But the more I think about it, this is such an important question with so many issues that it's not in my primary area of expertise. So I'm just not going to provide much more guidance until I get a personal better handle on it. And I know many of you are parents of kids or work in the school or work with or with somebody who's in this situation, and you need that information now. But the reality is is that it's really evolving, and there are a lot of different perspectives. There's probably no right or wrong answer, just more a lot of points that I think you need to educate yourself on and decide what's best for you all, given your values, your priorities, and really what's going on in your particular community and the area where your school is. And what's really adding to this confusion is just a lot of different information. You might have seen this report out of the CDC this past week, the importance of reopening America's schools this fall, and it's been picked up in the press, and you can spin it in a lot of different ways, but I think a lot of the press has looked at it as the CDC really having the tone, and I think this is true regardless of your political background, but the tone of the announcement from CDC, I mean, just the title of this is more on the emphasis of reopening. And the CDC really does make it a point in this updated guidelines to encourage school openings by outlining the process that has to be done. If you look in the detail, they put in sort of parameters that if you were to apply it to almost every county in Georgia, I think you could argue that basically what the CDC is saying is you should really be careful or slow down and carefully think about reopening. But the tone of the document is really more encouraging, if you will, or pushing the states to open. And my perspective is that it's just very politically tinged, and I'm really disappointed to see the CDC fall to that. But there are powerful forces at hand, and it's easy for me to say, but I mean that's how unfortunate it is. I think institutions like the CDC, where you would hope that it's a fortress for political wins and other influences, but I think this is a clear situation in which that's the case. I would not take the CDC's report to be any more encouraging all of a sudden. There's no new data or any information over the last couple of weeks that's changed the environment in our communities. So I think what all parents and educators and the people around them have to do is get the most education that they can from reliable sources. So there's a lot out there. Last week there was a document by the National Academy of Sciences that I have a link for that you could go to. It's a lot of detailed reading, and perhaps it's a bit more on the scientific side, but again, I think many of you would benefit from reading that, so go back and look at that video. And again, there's so many more resources, I'm sure, but one that's been advertised within our institution is this Facebook chat that you can watch that's recorded. Dr. King was the head of the National Education Association under the Obama administration, and then we have two infectious disease specialists, an adult one from Emory and a pediatric infectious disease specialist from Northwestern in Chicago. And this is an event especially for the education community and parents. So it's a good one for, I think, many of you to listen to. And this is a question that came up last week that I went over, but there's some more information that came out recently about signs and symptoms of COVID. And this is, again, through the CDC's scientific journal, the MMWR, but basically it's talking about, while there's a wide range of symptoms that can accompany the coronavirus, the CDC says a large majority of patients in this recent study exhibited one of three symptoms. That's fever, cough, and shortness of breath. So you can get really lost with these big lists, and maybe there's different lists depending on the source, but it really boils down to three major symptoms: fever, cough, and shortness of breath. And this was published last week. It found that 96% of patients had a fever, cough, or shortness of breath. and around 45% had all three of those symptoms. The most common symptom was cough at 84%, followed by fever at 80%. And of course, there's the other symptoms that coronavirus exhibits, including chills, muscle pain, headaches, fatigue, digestive problems such as nausea, abdominal pain, vomiting, or diarrhea. The CDC said that about half of patients reported one or more GI symptoms. Among these, diarrhea was reported most frequently at 38%. So it's most among the GI symptoms, but it's not most among all the symptoms. It's still less than half, or a little over a third at 38%. And vomiting was least frequent, about 13%. So maybe it'll give you kind of more of a clear idea. I mean, this is, again, in line with most respiratory viruses. We're talking about fever, cough, shortness of breath. Okay, that's the end. Again, I just want to thank Terry and the chapter, and go visit their resources, COVID and otherwise. Continue to support them, please. And continue to send your questions each and every week. And remember, stay safe, wear your mask, social distance, and we're going to get through this together. We will get to the point where things will be more normal. It may be a little longer than we hope, but I'm very optimistic through the development of treatments and vaccines, and especially education and working together, that several more months from now, and I know you guys want me to give you a date, but I'm just guessing probably somewhere in the spring or summer, things will be more normal. It won't be completely normal, but it'll definitely be better, I think. All right, have a great week.